what are the top 3 challenges you face with distal radius fractures?
I think the top 3 challenges that you see with fractures of the distal radius would be number 1, exposure, 2, fracture reduction, and 3rd, the position of the plate itself. I think it's really been helpful that with the release of the brachioradialis when you're talking about exposure. And when you release the brachioradialis, that really helps bring the radial styloid out to length and helps restore that radial tilt, which in the past that's been very tough to do. And that really makes it much, much easier. So we release the brachioradialis on virtually every fracture that we do. And the key with it is we release it in a proximal to distal direction. Because you got to remember that forms the floor of the sheath to the first dorsal compartment. And so if you release it in a proximal to distal, then there's less risk of injury to cutting the tendons to the first dorsal compartment. The second, obviously, is reduction. And I think we're seeing much less irritation of the flexor tendons now than we did in the past earlier when we first got started on reduction from the volar approach. Because we're really getting our volar tilt back where it belongs. And we make sure there's no gap between the plate and the bone. Because I think particularly if you're malreduced, or if your plate's not against the bone, those are the cases that you would start seeing some flexor tendon irritation. So as we've gotten better and better at getting our reduction and using a non-locking screw, sucking the bone to the plate, there's no gap, and we're not really seeing any flexor tendon irritation at all. And third, particularly is placement of the plate with the AccuLock. Now the nice thing about the AccuLock, it has a little bump to the plate distally on the distal part, and you can line that up with the sagittal ridge. And if you line up the sagittal ridge and then put the plate parallel with the shaft of the radius, that almost always guarantees perfect placement to the plate. And the nice thing with the plate, it's so anatomic, it just fits and finds its position to the fracture. And then with your screws, you get very good support to the articular surface. So the key, number 1, bump to the sagittal ridge, and 2, parallel with the shaft. If you do both those, that really helps line up the plate. And now with the newer guide, you can really help use the distal guide and use the laser lines on the fluoro to further help really make sure your radial styloid screws are going toward the radial styloid.